Hi everyone, thanks for joining me and Sal on this presentation. I'm going to talk about one of our ongoing projects on how we are using graphs to identify fraud, waste, and abuse from healthcare claims. Before I get started, a little bit about myself and Sal. So I'm the Chief Data Scientist in the AI Center of Excellence within Deloitte Risk and Financial Advisory, and Sal is our data science lead. We work in the same team, and for this particular project, we teamed up with our program integrity group within Deloitte to build this solution. And before I go into this specific topic, just want to talk a little bit about what fraud, waste, and abuse is about, and why we are dealing with this specific problem. So for those who are unfamiliar with program integrity or fraud, waste, and abuse in healthcare claims, it appears in multiple facets. So some of the problems besides what we are going to talk about today that we work on are, for example, if a patient is traveling for really long distances to see a provider, does that indicate fraud? Or when you see a doctor, and maybe if you have a broken finger, the doctor, let's say, prescribes you, a finger cast, maybe you need some stitches to your finger, but at the same time, the doctor prescribes an MRI and an opioid. Now, an MRI may be medically necessary, but anytime a provider prescribes an opioid is very questionable. Just to give a couple of examples of where we are going with fraud, waste, and abuse generally. More specifically, for this talk, we are going to talk about once we identify a few different risk signatures of healthcare providers, and we have over 100 different rules and models to flag risks for providers. How can we identify providers who share some similar risk signatures with other providers? We base off an anchor and then try to find other providers who share some similar traits using graph neural networks and machine learning, and try to rank order them. And then we have a way to validate them using some subject matter experts who help us validate our results. Why is this important? Why is fraud, waste, and abuse identification important? I think the answer is threefold. So first of all, if you think of this example that I just gave about opioid prescription and so on, you can think that obviously it relates to quality of care and patient's health, and it impacts that. So that's the most important issue of why we want to tackle fraud, waste, and abuse. The second topic that we want to address is, if you look at the U.S. healthcare expenditure, it's about 20% of the GDP. And fraud, waste, and abuse accounts for somewhere between 3 to 10% of healthcare expenditure. So it amounts to over $100 billion that's lost to fraud, waste, and abuse. And the third reason is that if you're a fraud investigator, and this is one of the drivers of our use case as we work with our program integrity team, is that if I'm a healthcare investigator and I start off with one of the known bad actors, I want to find who are the other bad actors that may be connected, not directly, but share some traits with this actor, with this bad actor, and how can I identify other similar providers? How can I rank order them, simplify my investigation, and maybe create class action? So that's so these are kind of the three motivating factors for why we are looking at this problem. And just to give some examples of like real life examples of where you see this manifested, and just 3 news articles from the last month and a half. In the first example, you have woman in Mississippi sentenced, for 57 months because of healthcare fraud. And in this specific case, she's basically ordering DMEs or durable medical equipments for her own business, while that is not something that has been prescribed by a provider. So basically, these are all false prescriptions, and she's acquiring these DMEs for her own business. In the second example, we have a chiropractor, and what this person is doing is basically, lying about patient claims and, defrauding the health insurance system of about $2.2 million and 500 patients and their families impacted through these fraudulent prescriptions, treatments, and practices. And in the third example, you have a pharmacist who is, paying for certain like fraudulent prescriptions and providing kickbacks to providers who refer patients and procedures and equipments to this pharmacy, which are actually not needed for a patient. Just to sum it up, what we are looking at are federal healthcare claims, primarily Medicare and Medicaid. As I said, there are over $100 billion, as of 2019, and this number is growing. That is lost to fraud, waste, and abuse in healthcare claims fraud. And obviously, from the regulator side, there's a mandate to investigate this, to look at this. And how we do this is to build a graph that is centered on providers, and Sal will take us into how we are building this graph. And then we apply graph data science algorithms. We build our, we model our data in Neo4j. Then we apply some off-the-shelf GDS algorithms, but we also follow some of the state-of-the-art algorithms, which, some methods that we are following from the academic research and applying those on top of the graph that we have built on Neo4j. And just a quick rundown of the agenda. Sal will talk about the problem definition, why this is important, what we are looking at, and how do we solve this problem, and what are some of the challenges that we faced as we build this solution. The primary question that we're trying to address is, as a fraud investigator, I want to detect all providers who share some similar risk profiles with others, and it's primarily driven by their behavior, not necessarily, I'm one hop away from a known bad actor and I want to find that, but it's more, looking at the data more globally and try to identify, traits based on risk factors. There are various constraints that were placed, on how we build this graph. One is we want it to be claim agnostic, so our graph is an egocentric, provider-centric graph. So everything is tied to the provider, not individual claims. The other aspect of it is, we wanted to be location agnostic. So, we are dealing with Medicare and Medicaid programs across different states, and we wanted to build a model that doesn't depend on, any state-related, data biases. So we wanted to be agnostic of that. And the third is, we also didn't want to be, focused on certain, diagnostic conditions of patient or, certain procedures. We wanted to be agnostic of that and, build something that's very general and can be applied generally across the different states, Medicare and Medicaid claims. I'll hand it over to Sal to talk about the solutions, and then we'll come back on the takeaways.
Yeah. Once again, thanks for coming. And if you guys have any questions or something isn't clear, let us know. So in exploring the solutions, one of the first things we decided to do was to take our tabular data stores and move them into a graph. So we go from, we also selected Neo4j graph database engine to utilize the built-in graph algorithms and the power, the computational optimizations that you get from this particular graph engine. And more importantly, we rely on algorithms that are built for node similarity, clustering, and community detection, which is some of the things that we're interested in this work. So we began by looking at and exploring at length the data, selecting tables, selecting features, and then building a graph schema. And it takes collaboration with our stakeholders to build a proper graph schema for a problem like this. In our development environment, one of the things that we did is we took a sample of claims or a sample client database And then from about 11 million records, we were able to select and clean and process some of the data so that we could end up with a graph stored in Neo4j that has about 4.8, 4.9 thousand or 4.8K providers. We have about 32,000 diagnoses, 7,000 procedures, et cetera. And so that's what our data ended up being currently maintained in this particular graph for this problem.
Did you already talk about whether this is supervised or unsupervised, or how much confidence you had in your?
Yeah. So the solutions that we're developing are unsupervised. So we have no labels. We have no sense of other than the basic information that you have in a claim or in a provider's database, where you have this provider has this particular specialty, and so you could say these are similar. They work maybe at the same place, so they could be said to be similar providers, or to have similar characteristics. But we're interested in more than that. So we don't have. So when you look at the underlying data, the underlying behavior of how they build claims, then there's more information that is difficult to compare, right? And so we don't have. So given their behavior in submitting claims, we don't have labels for these two providers are similar, and so we don't have labels for that. So it's a non-supervised problem as we developed it.
Okay, I was just thinking of that previous comment where you mentioned anchoring based on
Yeah.
the provider with suspicious behavior.
Yeah. So, I mean, the way we do it is, and he'll talk more about this. So the subject matter experts, they know who the bad actors are. I mean, when we start building the graph, we go in without any knowledge of who they are. So, we build it more generally, but we have risk factors associated to every provider, across these like 68 dimensions. So we have some idea about how risky their behavior is. If not, just, like saying 0 and 1, like, this is a bad actor and this is not. And then, as we validate it, we again go back to this maze. We show them the rank results. We ask them to, say, who are the most similar, who are the most dissimilar, some are somewhere in the middle. And, we'll show some of the results of how the ranking works.
Yeah. So this is kind of a general view of what we end up with. Then what we focus on next is exploring different algorithms. We obviously make use of Neo4j for its optimized computation. We explore node embeddings, algorithms such as FastRP, fast random projection. We also employ and use k-nearest neighbor to give us an idea and to balance the computational costs that you can see when you scale to larger graphs or full data sets. And then we use the Jaccard algorithms. Again, these are built in Neo4j to examine further or at length some of the similarities and then compare that against the underlying data. Here's a visual representation of the workflows that we're currently exploring, where we start out with some node embeddings using a weighted graph, and we utilize fast random projection just to get an idea of what the vector representation for a particular provider in the graph looks like or is. And then we use k-nearest neighbor algorithm to derive a fraction of provider pairs and have some sort of notion as to how similar they are just based on the node embeddings that we're able to derive. And then we use Jaccard algorithm to then integrate that knowledge, that initial knowledge based on k-nearest neighbor, to then add an edge to the graph to a fraction of the providers in the graph, and then run Jaccard similarity to get our final set of node similarities, and then be able to use those for evaluation. So those are the ones that we bring to a domain expert, and then we ask them, based on the underlying data. So they don't see the score; they just see the underlying data. How would you label this pair providers? We started out with two approaches, and I'll go into that in a minute. But first, I want to come back to how it is that we build the graph schema. So we were talking about earlier about how we have to manage or balance the constraints of of the stakeholders with how it is that from a graph-theoretic approach, you would build a graph and what are the, how you end up selecting what is a node and what is an edge, or what is the weight on the edge, and what are the features that you add either to the individual nodes or the features or properties that you add to the edges as well, right? So you can combine everything and be able to have multiple options of how you come up with this final solution. So in our case, we wanted to address the fact that we're not supposed to use claim numbers, but we want to encode the volume of claim numbers a provider has submitted claims for payment and are in this graph, right, or in this data set. We also can encode the volume of patients provider has, but not necessarily have any patient-specific or patient population-specific information, as well as, and then we limited it to the place of service, which is not necessarily tied to a geographic location. So we also kind of eliminate geographic location, but provide some sort of a notion of where are the services being provided.
Quick question.
Yeah.
One thing I don't see there are outcomes, patient outcomes. Was that ever a factor? Because you would think that you could potentially have a provider that's doing something different that would appear as fraud, but if their outcomes were superior.
Very good observation. I like that. So one of the things that we add in this graph is most of the data that makes up this graph schema is data elements that are available in the claims, right? So procedures, diagnoses. In addition, our team at Deloitte, they also run a set of other machine learning algorithms or rule-based models to come up with a list of risk scores, and you can see there at the bottom. So the risk indicators would capture that sort of information, and then they would give that provider a score on that factor.
So it does get factored in.
So it does get factored in. So in addition to this, one of the things that we're going to be exploring is, in addition to the basic schema and the basic set of features that we select, is we're also going to be exploring other properties that are in the claims or properties that we can derive implicitly out of the graph based on the topology, such as degree centrality, eigenvector centrality. We can also borrow from other places, such as PageRank, and add those to the nodes in this case, and then continue to test and see how we're able to improve the results of the solution. And if we look at some of our initial results, here you see that we were able to get, again, an initial pass of how our schema and how our particular graph looks like when we employ k-nearest neighbor. We can also, again, take that k-nearest neighbor, integrate it, and combine it, or integrate it, I should say, and then apply Jacquard similarity to get a better view of what the distribution, to get a better view of the distribution of that similarity. You can see that in the k-nearest neighbor, obviously we're gonna have only a selection of providers where our results show that a lot of them are similar, but it doesn't give you a good picture overall, a holistic picture of how similar they really are compared to the rest of the providers in the database. This also shows our results that we're able to get when we use a ranking approach to how we sample from the results. We sample provider pairs, and then we bring these to a domain expert. They can then label for us whether they think these providers are similar based on the underlying data, dissimilar or neutral. And so we started out with that approach where we had 3 labels. So we had kind of like an idea of that using a multi-label approach, and started out with 3 labels, and we ran into some problems. And so we also addressed those by using a ranking approach. And so here is the results of our ranking approach. To give you a better idea of how that validation took place, right? So you have it's hard to see here, but you have each pair, here you see pairs of providers, and this is what the domain expert sees. So they look at the procedures that were submitted for each of these providers, diagnoses, places of service. And so based on that information, they then select one of the three labels. And then that was the task one on the left. And then when we were trying to make sense of those validation results against the scores that we got, it was difficult to find that separation of what is similar and what is dissimilar given the scores. So to get a better idea, we selected a ranking approach where the object now is how good is the model at ranking these pairs of providers as the subject matter expert, as the domain expert would rank them. And so that's what you see on the right. And that's what we selected and computed our model performance based around.
Sorry, quick question.
Yeah.
The second task about ranking, they're ranking pairs. The first task totally makes sense. So you're
Yeah.
a provider, you're given two pairs, and you get to say similar,
Yeah.
dissimilar, whatever.
Right.
And then the ranking, I don't understand.
So the ranking in this case, if you take an anchor provider and you look at its, let's say its top 10 similar providers. According to the model, these are the top 10, right? Then if we ask a subject matter expert, how would you rank if we give you? So what we ended up doing is we selected the top two, the bottom two, and one from the middle from this top 10. So then we ask, how would you rank them? And so then the ranking became 5 different options where it's like most similar, somewhat similar, neutral, somewhat dissimilar, and very dissimilar. So then that changes the way we validate, right? Now we're interested in how well is the model at being able to rank similarly to a subject matter expert. Does that make sense?
Yeah, I'm not super familiar with the literature. Are both of these tasks like literature standards? Or are these novel tasks?
Yeah. This is also similar to how you would do a recommendation system. So how, like when for example, when you bring up a list of results, is like how likely. There's a ranking mechanism to tell how well is the model, can the model rank the results that you see, for example, when you do a Google search, right?
Compared to humans, yeah.
Compared to what you're likely to select. Yeah. Okay.
And just to maybe add one more thing, and these metrics basically take into account, like if you look at a ranked list, if it should be, let's say, the first search result you are predicting is at number 5, while it should have been number 1. So it'll kind of penalize the ranking, and then if you get it right, it'll just improve your score. So it just matches up what the ground truth is to what your system is finding. And these two metrics are very standard whenever you have any kind of a ranking system, be it search engines, recommendation systems, even in surveys, these are used so the scale we follow is called a Likert scale, like a 5-point scale, often used in surveys. So, and then we map that Likert scale to a rank of 1 to 5.
Yeah, so in information retrieval, these are very standard metrics. So when we take a step back and we kind of analyze, what are we finding so far? One of the things that we initially found was that aligning the validation labels to the similarity scores, one challenge we had there is how do we delineate, what is similar from what is dissimilar, given the range of scores that we get from the algorithm. And then the other interesting thing that we found is that the subject matter experts hold and have a lot of information that is difficult to quantize, and it's difficult to put into the model. So one of the things that we learned from them is that they have a lot of ideas of how certain providers are similar, even to where maybe the data doesn't quite support it, but it's because there's a whole set of layer of information they have access to that they have acquired over the years that that allows them to say, and explain, well, they're not similar because, they just have they may be billing a lot of claims, but the claims may be fall under some sort of category that doesn't really fit with what we're seeing from the model. And so that was interesting. And so that was also one of the other ideas that gave us, that was one of the other things that we decided to, why we decided to move to this ranking system. Yes?
Have you considered all the connections, like different type of participants, like attorneys and, hospitals,
So,
organization for...
Yeah. So we made a deliberate decision to eliminate and only to eliminate facility type providers and focus only on professional providers. So if you individuals like physicians, like your cardiologist, your dentist, that type of individual, right? Because a facility, for example, a hospital or a clinic, will have a wide-ranging set of combinations of procedures and diagnoses that forces you to maybe develop a different type of algorithm for that kind of similarity, and in this case the requirements were that we wanted to, and this is one of the requirements from our stakeholders. They wanted to they're interested in just individuals. Because I think it's also maybe easier to...
They don't mention anything about attorneys, because attorneys are very important.
Right. But in this particular case, right, so yes, there's many ways that you can look at this problem, but one of the things we wanted to do is just based on the claim behavior, the billing behavior of the provider, how do they rank? Which ones are similar, which ones are behaving similarly.
And just to add to that, you can have, we have claims, let's say, for emergency room visits or nursing home facilities and so on. But anytime it's hard to attribute a claim to an individual provider, and you have to do it at an institution level, we don't approach those.
Yeah.
Can I change your question?
Sure.
I know that the ICD code very hard to do data prep. You have any special secret sauce? Also, procedure code as well. How would you aggregate them into the level that you can visualize the graph as an attribute or those attributes?
So what you're asking, for example, is how do you use ICD codes, like in a machine learning algorithm, where your sort of your universe of ICD codes is relatively large, right? Yeah.
ICD code.
Yeah.
And then how would you connect them? Is it one provider would have, 10, 15, 20?
Yeah, so in this case, right? So in this case, what we do is we bring in your claims, right? And so if you're the provider, right, and you have, let's say, out of, I think I said about 32,000 different ICD codes. So if you prescribe or you mark your bill, you bill for, let's say, 10,000 of those, right? In the graph, you're going to be connected to all those 10,000. But then the edge will have a weight that tells us, how often you bill for this one diagnosis, right? So it follows. So for example, right? So what would make it very easy is if 90% of the time you bill for these 10 ICD codes, and then or the other way around, right? There's maybe 10 out of 100 or 10 out of whatever number I said initially, and you have just a huge number of claims that are being submitted against maybe a few number of ICD codes, then that could trigger some anomalies for us to be able to investigate further. Yeah, but in the graph, you are connected to all of the ICD codes that you are listing in your bills.
One just interesting addition to that, since ICDs follow a hierarchy, you can say, the discrete codes, maybe they are not related, but if you have two providers, who have some, let's say, discrete ICD codes at the lowest level, which are not connected, but at a higher level, at a parent level, maybe they are connected. So there's a way for us to also overlay an ontology on top of this, so that we can also kind of bring things together. And that's, some of the next
and
things that
group
we are
things together.
You try any kind of embedding
Yeah.
on ICD
Yeah.
code to group them together
Well, in this case, we focus on the embeddings for the providers because we're interested in how the periphery nodes characterize the provider. So that information is being aggregated into the provider at the provider level as embeddings at the provider level. Yeah.
I mean, we have some separate use cases where we are doing that. Like, basically we are building like diagnosis code embeddings and procedure code embeddings based on both the hierarchies as well as data driven from the claims, because at the claim level we always have a connection between a procedure and a diagnosis. So you have that from the data and then you can overlay the ontologies on it.
Yeah. Question?
Do you get cost data or payment data?
Yeah.
We do have cost data and payment data. We also have risk factors associated with payment. And there's and we bring them in, or we can process them at two levels. We can process them at the risk level, right? So, given their cost behavior, the way the amount of money, right? The amount of money that they bill, there might be some model that specifically targets a certain behavior, and then it scores you based on that.
And you take into time into account?
Temporal. Well, yes. So one way of it's not directly. It's sort of it's indirect. It's indirect. So for example, it is the number of claims that the graph is amassing over time, right? So if you start out, if you're a brand, this is your first time submitting claims, and you make it onto our graph, you'll have 10 claims, right? Over a period of 6 months, 10 months, you'll have higher claim volume that is now part of the graph. And so that's one way of handling time. Yes?
How do you handle the dimensional, high-dimensional capacity codes? I mean, some of them are very commonly prescribed, and they could trigger a similarity between providers.
Yeah. I'm glad you mentioned that. So one of the ways that, so we have in parallel, we're looking at other state-of-the-science algorithms or methods that'll help us address that specific question. So what we decided to do was to look at SIMPGCN. SIMPGCN from the recent literature. It's an algorithm. It's a framework that allows us to weigh and select how much a node contributes in the graph, or how much an edge contributes in the graph. And so this is an architecture that allows us to do some pre-processing to the graph, and then run it through a GCN, and then also use supervised learning, self-supervised learning, to continue to further bring those providers that are similar and increase the gap, or increase the separation where you have providers that are dissimilar. And so that's the other work that we're looking at, where instead of just using the Neo4j features or the Neo4j capability out of the box, we're also exploring with the graph in Neo4j, applying these other methods from the literature. It allows us to explore an alternative solution, right? An alternative solution to the problem. Why? Because in this example, SIMPGCN provides a lot of feature preservation, so that when you run it through a graph neural network, the aggregation step within the neural network doesn't sort of filter out, or it doesn't filter out those key features that might be interesting, might be important, while at the same time also diminishing the contribution of for example, certain ICD codes or certain procedures that are just so routine that they could bias your similarity in one way or the other. So, roughly, the way this works is you start out with your input graph, and then you derive a feature adjacency matrix, and you start out with also the regular adjacency matrix that you get from the weighted topology of the graph. And then it runs it through a learnable self loops, and these are the self loops that allow you to tweak and allow you to set how much a node or how much a property should be contributing to the overall graph. And then you run that through your GCN. When you get to the next to the last output layer, we take that embedding, or we take that layer, and then we combine it again with the original graph's adjacency matrix, and then we run it through the self-supervised pipeline according to the SIMPy-GCN. And that allows us to then do cosine similarity to be able to have access to all of the possible pair combinations. And so I mentioned earlier that we have about 4.8K providers, and so that would end up having up to 11 or 12 million pair combinations. So if we really wanted to, for development purposes, to investigate, every single pair and look at every, we won't do that, but you would be able to do that with this approach. And so the results of this we're going to be presenting at a conference, at a research conference, and so look for that in the near future. So some of the insights and takeaways from this, I'll let Sanmitra finish us out with his thoughts and his views and how this is progressing.
Yeah, thanks for that. In terms of where this project is, as you hear about some of the numbers of how many providers, how many claims we have, how many ages, these are all based on some preliminary R&D that we are doing. The actual volume of the claims, is in hundreds of millions, and how we scale this approach to that level, that's something that we'll have to see. Especially some of the new approaches that we're exploring, they look very promising. And as you move out of the box, from non-Neo4j algorithms to some of the state-of-the-art, they have additional compute overhead. So how this can be scaled up to hundreds and millions of claims, that's something that we'll explore. One of the challenges that I think anyone who works on any fraud detection, anomaly detection, outlier detection problems is that often there's no label data, and that's also something that we encountered. When we initially, thought of this problem, we thought that, it'll be very easy to find similar and dissimilar providers. Maybe we'll find a threshold of a probability score, above, let's say, 0.5, they're similar, below 0.5, they're dissimilar. But that couldn't be farther from the truth. It's really challenging to actually find, for a given provider, let's say I have a given anchor provider, I have let's say 10 other similar providers, the most similar provider in one case could be 0.3. For another provider, the most similar provider could be 0.9. So you can't pick just a uniform threshold to apply across your entire data set. And that's why we went with a ranking-based approach. And I think as you think about how you apply GDS to your solution, I think we spend a lot of time in I think the algorithm development part is probably easier and sometimes faster. As Alicia showed this morning, you can run some of the algorithms in 3 minutes or so. But I think getting your data into the shape of a graph data model and coming to an agreement with your stakeholders that this is something that's appropriate representation of the data. I think that's probably one of the most challenging parts. And then the validation also, once you see the results, how do I know, how can I be confident that these results are actually useful? So I think these are the two components also probably are the most challenging aspects. Like I said, this is some work that has been done over the last few months, but I think there's a lot more work to be done as we scale this up. We have submitted some of these results both from the Neo4j evaluation plus the SIMPy-GCN based work to the KDD conference, and if it gets accepted, you will hear more about this work. Yeah.
So in your claims database, do you get the name of the physician?
So when we build the graph, we see the ID. Everything else is redacted.
Okay.
Yeah. So no, especially for the R&D phase, we don't use any kind of sensitive information.
Okay.
So all are in the form of IDs or they have some representation.
Physicians don't, HIPAA doesn't apply to physicians, so, but you don't have that.
We don't. I mean, you could have like an NPI ID through which you can like go back. So they're all identifiers that are there.
What was the thing that you said about it doesn't apply to physicians?
Typically in a claims database, physicians can be identified
Yeah.
in an open claims database. Patient data is all those things.
Right.
Yeah.
Be identified, their information.
Yeah. So in our claims, we have information such as the MPI,
Oh, okay. Then you have
but it is not the ID that we use just because of.
because of the NPI, you can get the name of that.
But exactly. So you would have a whole lot of information, and then through that, you could then bring in attorney information or any other sort of,
And then with that, you can have a labeled data set, because you can look in the news and see who's been convicted.
Yeah.
Yeah, that is.
So like the OIG maintains this database, right? Like,
Right.
who are the convicted individuals,
Right.
and that's something we use.
But what's fun about this project is you can never know that these patterns of fraud sometimes morph over time. So just because you found one and you convicted one last year doesn't mean that you're going to quickly see that pattern again. And that's why fraud is fun.
Yeah.
Yes.
So when you compare the similarities, were you focusing on just random cases, or were you focusing on fraudulent cases?
We were focusing on, we were selecting essentially at random. We're selecting two pairs, looking at the underlying data, so looking at their claim behavior, and based on what procedures, what places of service, then we assess, right? We assess, or we ask the subject matter expert to assess, right? So that when this is used in production, right? If you are one of those investigators and you have an individual targeted, you want to know what others in this database are behaving exactly like this individual, for you to continue the investigation process.
Yeah.
The reason why I ask is, bad guys, fortunately, are a minority. Right? So whether your approach works very well for finding similarity for the 99.9% of good guys, I'm wondering whether that approach is still valid and has been validated for the point whatever percent that are the bad guys.
Yeah, I think generally we are tackling whether how good the ranking is. We assume we don't have, obviously there are some authoritative sources to go by when you want to find who are the actual bad actors. There's a Office of Inspector General, they publish a list over the last year who has been convicted, but not anything current. But we assume, let's say we don't have knowledge of that. We look at, how good are we with ranking without that knowledge, like similar providers. Now, as an investigator, if you don't care about someone who you don't think is fraudulent, you will probably not look at them. You can plug in a given provider's ID and try to find other a rank list of providers similar to them. So in general it could apply both for fraud and non-fraud. But you're right. I think down the line, as we monitor how this is applied to the real world data, we'll be able to say whether we see a difference in how it behaves for non-fraud cases versus actual fraudulent actors.
Yeah. So it's all on how good you're able to capture this low-level noise in your data, right? That potentially contributes to a behavior that is an anomaly. So this work will be part of an anomaly detection system, an anomaly surfacing signaling system. That if you're an investigator, given all your knowledge, right, and your network of access to this type of knowledge, you'll be able to say, you know what, this doesn't look like it's someone I should be concerned about, but there is this one thing. Let's look more for that, right? It's just exploring your universe of individuals in this case and how they behave. And then more importantly, can you quantize some aspect of how they behave around claim submittals. Yes?
Can you quickly touch upon the topology of your graph neural network and the node features that you're using?
You want to talk about
Go
it?
ahead.
So it's basically, everything that you saw, like in this slide. So everything that goes into the Neo4j methods, all the same features goes into the graph neural network.
And do you pay any attention to the type of edges? So the GCN you said, so it's a pretty much homogeneous graph.
Yeah, I mean, all the edges are weighted based on, like the volume of claims and the number of members that a provider sees.
Yes, the only thing I can add is that if you can see there on the top diagram or on the top schema, so it's how we define the weights that we thought, okay, we want to be able to encode volume information, right? So we don't want to have a node for every claim in the graph, right? So if you have a claim number or a transaction number for those people who are in the finance, we didn't want to have a node for that, right? So instead, we focus on the individuals and we quantify their behavior by how many claims in the graph they have. And so that's how we use our weights. So our weights capture proportionality of the volume of claims. Another way that you can then switch out is the volume of providers, the volume of patients, that they have, that they interact with, right? The same thing you could do for drugs. The volume of drugs that they're prescribing in the encounter, you can also encode that in the edge.
Yeah.
Do you have a problem with the place of service? Like, how would you normalize? So there could be like many similar addresses or location, but it represents one for one entity.
Right. So we're not interested in location, remember? We're not interested in the specific location. We're interested in the type of place the service provides.
So it's like inpatient, outpatient, like that level, not like at a city or state level, just because we wanted to be agnostic of the actual location.
Any reason why that wasn't important?
Yeah, for me it's very important.
Yeah.
It's really important.
What was the rationale for why to exclude that?
Yeah, I mean, there are some other, some of the risk factors that take into account, like, let's say, a distance between a patient and a provider. So, I think that's something that's a very critical factor, as we build this graph. I mean, kind of to reduce the redundancy of things that are captured by the risk factors already, and then augmenting, stuff that are not captured by the risk factors. But I think, I mean, these 68 and in the actual data, there are close to 100 risk factors, which take into account different facets of, locations, other behaviors, like I said, upcoding, overutilization, things like that.
Yeah.
Did you?
Question over there?
Just a quick follow-up. Did you, in those factors, did you include demographics and other things of locations?
Some of the factors include demographics. I mean, it depends, whether it's at the risk level. So, for example, a male patient getting a pregnancy test, that will flag one of the, flags and edits we have.
One of the risk factors will.
What do you think in terms of local location aspects, where this community has a certain profile?
Well, no. Remember, one of the constraints we're balancing is this constraint that they want to be location agnostic and essentially demographic agnostic. We want to know. We don't want to encode patient information. We want to focus and hone in on how is the provider billing, right? And because this provider could be anywhere in the country.
I guess the question is why?
Yeah.
Why?
Why do you not take that into account? Because
Did your stakeholders tell you not to do that, or did you all decide to eliminate location?
It's our stakeholders primarily. Most of the constraints are, the fraud investigators. I mean, they kind of, they explain to us what they want, and then how, we interpret that and, put that into the graph. that's a choice we make.
Yeah. So this is not like a decision made, out of the blue. So it is driven by the investigators' knowledge and experience in the biases that come from having patient information and location information. And so given that, they stated this constraint.
Yeah, the only reason I'm asking is because I don't know if it's true in this industry, but when you're looking at credit risk analysis and stuff like that, you can't use location information because it becomes an analog for things that you can't do, like race, demographics.
Exactly.
Right.
So
right.
it's eliminated because it will compromise your end game, right? Because as soon as they can prove that you've got something that's an analog for a demographic,
Yeah.
and then in the end they can throw something out of court because they can say it's biased.
Yeah.
You don't want to end up in the front page of a newspaper doing that. Like,
Credit bias is one thing, but fraud bias is a different thing, right? That's why I'm a little puzzled by that as well. It may be a decision that was made with a white blanket, but
Yeah.
it's going to hurt you in the end game.
There are ways to still correlate and maintain the, not being over biased, but still
Yeah.
using location in a way that's still interesting, but follows the guidelines from a PHI perspective around these types of biases.
yeah. We're kind of focusing on the risk factors, right? So everything is focused around the risk. So some of the risk factors will capture if there are certain kind of anomalies based on the geography, locations. So it's so that's why I said, it's all foundation on the 100 different edits and risks. So some of the things that we're thinking of would be flagged through some of the other models, and then we're building on top of it.
And we also felt exactly like you. We asked these questions at the beginning because we're trying to understand the motivating factors for that constraint. So I'm hoping that later today we run into some of you guys and talk more about that at length.
Jeff, you're going to say something.
I was just going to say, look at the examples you had in your slides. Some of the fraud cases you had as examples, some are in California, some in Florida. So when you're doing similarity comparisons on providers, if you do it on location, sometimes it puts your population set so small that you miss the broader ones you really want to compare against.
Yeah. Yeah, interesting constraints that we all have to navigate these days. So, thank you very much.
And thanks for all the questions. Yeah.